Dale nomás.
Ahora sí. Tú me dices cuándo.
Ok, Gustavo, entonces, estás transmitiendo en vivo.
Muchas gracias,
Partimos en,
Mauricio.
estamos en 3, 2, 1.
Hola a todos, ¿cómo están? Espero que bien de salud junto a sus familias. Bienvenidos desde la carrera de KineUC a nuestra charla número 27 de este ciclo de webinars gratuitos. Muchas gracias a todos los que están conectados en estos momentos a través de nuestro canal de YouTube. Estamos muy agradecidos por la recepción que han tenido nuestros webinars, incluso llegando a más de 9.000 visitas a la totalidad de nuestras charlas. Estamos contentos de poder seguir entregando información a nuestra comunidad UC y a la comunidad en general. Como ya es de costumbre en este ciclo, quiero entregar un saludo muy especial a nuestros alumnos Kinesiología UC que nos han ayudado a promocionar nuestras charlas en nuestra querida comunidad estudiantil. Y por supuesto, esperamos que puedan seguir ayudándonos para llegar a cada día más gente con estas charlas gratuitas. Como primer paso, quiero dejar los invitados a seguirnos en nuestras redes sociales, en Instagram y Facebook, y además visitar nuestra página web donde encuentran mucha información descargable de utilidad. Además, dejarlos cordialmente invitados a nuestro canal de YouTube con más de 600 suscriptores, donde tendrán información de interés para ustedes, que creo que les puede ayudar en todo lo que puedan entregarle a sus pacientes. Segundo, quiero decirles que las charlas están quedando guardadas en nuestra página web, en el link que ven en la pantalla, para que todos los que se están perdiendo nuestras charlas puedan ver la información de las semanas anteriores. Ahora les entregaré algunas instrucciones generales con respecto al webinar de hoy. Por favor, pueden ir dejando todas sus preguntas en el formulario de YouTube en el cual están, a la derecha. Les aparecerá el formulario donde pueden dejar sus preguntas para que nosotros podamos leérsela al final de la charla al profesor Chad Cook, que está hoy día con nosotros. Por favor, realicen las preguntas que estimen convenientes. Además, queremos invitarlos a contarnos sobre los temas que les gustaría que se realizaran las siguientes charlas a través de menti.com. Ingresen a la página y luego ingresen este código y pueden responder 3 temas que les gustaría que se tocaran en nuestras próximas charlas. En esta nube que ven acá son los resultados que hemos tenido hasta el momento. Para nosotros es muy importante la opinión de cada uno de ustedes para empezar a programar las siguientes charlas. Si es que se dan cuenta, algunos de los temas que ya hemos tocado fueron ideas que ustedes propusieron. Por lo que, insisto, por favor voten, ya que para nosotros es muy importante la opinión de ustedes y así programar los siguientes invitados. La primera parte de la charla será la presentación del kinesiólogo, doctor y profesor Chad Cook, y al final luego pasaremos las preguntas de ustedes. Hoy hablaremos de un tema que para mí es algo que me apasionó muchísimo en mis inicios de carrera como kinesiólogo, como es la terapia manual, pero lo interesante es que el profesor nos va a hablar de los mecanismos subyacentes de la terapia manual y sus implicancias en la rehabilitación. Y para esto tenemos un exponente de lujo, un exponente de marca mundial como Chad Cook, y nos va a contar sobre algo que increíble que nos va a mostrar. Darle las gracias desde ya al profesor Chad Cook por estar con nosotros. El doctor es un investigador clínico, kinesiólogo y defensor de la profesión con un historial de excelencia y servicio en la atención clínica. Sus pasiones incluyen refinar y mejorar el proceso de examinación del paciente y validar las herramientas utilizadas en la práctica diaria del kinesiólogo. El doctor Chad Cook es autor y coautor de 3 libros de texto, ha publicado más de 250 papers y ha impartido conferencias a nivel mundial sobre examen y tratamientos kinesiológicos. Tuvimos la suerte de poder contar con la presencia en Chile hace algunos años del doctor Chad Cook, y puedo decirle que realmente es una tremenda y gran persona. Él es certificado en manejo del dolor crónico de la Universidad de McGill, es PhD y aparte de eso también es MBA. Dale las gracias al profesor Chad Cook y le cedo la palabra para que pueda comenzar con su presentación.
Well, hello, everyone. I am so happy to be here and very pleased to work again with my very good friend, Gustavo. He is correct. I was in Chile. I had a wonderful time. It is a beautiful country, and the people are even more beautiful than the country. And I'd like to welcome the other individuals on this presentation from Peru and Ecuador, and Mexico and Brazil, and hopefully Argentina. It is my honor to be able to speak about this topic, which I find very interesting. Before I start, I'd like to thank Natalia for translating for me. And if you're listening in English, I'm going to speak slowly just to make sure that the translation is clean and clear. I'd like to give a little bit more background in addition to what Gustavo talked about. I do have a manual therapy textbook that's in its second edition. I am a fellow of the American Academy of Orthopedic Manual Physical Therapists, which means I've gone through the highest level of training in the United States and have received fellowship status. And for approximately 20 years, I taught manual therapy courses with a group called the Maitland, Australia Physiotherapy Seminars. I now teach courses on my own. I do a lot of research on manual therapy, and out of my 250 plus publications, about 50 are on manual therapy. I have been involved in dissemination of evidence for almost 20 years. I was the former editor of JMMT, which is a manual therapy journal, and I was an associate editor with Manual Therapy when it was also a manual therapy journal. Now, I am a senior associate editor for the British Journal of Sports Medicine, and I am the special topics editor for JOSPT. So again, thank you for attending. I'm assuming you have some interest in manual therapy if you're willing to listen to me on YouTube. I think manual therapy is incredibly interesting and it has a very rich history. And you may not know this, but in the Old Testament of the Bible, manual therapy was described and was people were treated with manual therapy thousands of years ago. And also the father of medicine, Hippocrates, used manipulation methods in the 5th century BC. It was used in the 1800s by Swedish physiotherapists. These were the first physios on record in the world. And between 1921 and 1936, in the Journal of Physical Therapy out of the United States, there were 21 articles that were published on manipulation. So for physical therapists, we've been using manual therapy techniques for a very long time. It's nothing new for physiotherapists to use manual therapy. Most of our manual therapy approaches have been influenced by a few people. These 7 people, Stanley Paris, Robin McKenzie, Jeffrey Maitland, James Syriacs, Brian Mulligan, Ola Grimsby, and Freddie Kaltenborn, have been the most influential individuals in developing the philosophies behind manual therapy. Maybe you're similar to me, that you've gone to a course and you've spent an extremely long period of time learning about a particular philosophy with manual therapy. The philosophies were created before the science was really known about manual therapy. And now we know a lot of things that we did not know before. A couple of older surveys from 2004 and 2005 showed that most orthopedic physical therapists were influenced by these manual therapy philosophies, and they often sided with one of those 7 individuals. In other words, they may say, I am a Maitland therapist, or I am a McKenzie therapist. People are much less likely to do that now than what they were in the past, but these philosophies have continued to live on over the years. It's actually become somewhat of a guruism, that they are these leaders and they have many people who follow them, and they take their word as if it is gospel or religion. And that was troublesome for a very long period of time, because many of the leading manual therapists did not agree with one another, and many of their philosophies were completely different than one another. Some of the individuals actually suggested that the treatment interventions were magical and special and were mystical in their benefits. I remember attending courses in the 1990s when the instructors would talk about the mystical effects of manual therapy. And we now know that it has no mystical effects, that it's no different than any other pain modulatory approach. So manual therapy is not magic. Manual therapy is just another form of intervention that we as physical therapists can use. What I'd like to do is spend the next several minutes talking about the facts behind manual therapy and the manual therapy mechanisms. I want to make sure that everybody that is watching really understands what manual therapy can do. I want you to understand how it influences the body and how it influences the mind, and really look at the science behind it, not the magical behind it. The science of manual therapy has actually been studied quite vividly, and I want to talk about those results. There are many different theories that were created by the philosophical approaches of manual therapy that just don't hold up under modern science. The concept of subluxation, in which the joint actually goes out of position in the spine, is not true. And this is a concept that is advocated by chiropractors. The idea of positional faults, that you'll see a variable placement of the spine, which is advocated by osteopaths, is also false. There is no known records of these. Coupling theories such as Fryet's laws, which you may have learned in school, have not stood up to modern assessment. Kaltenborn's convex concave rule, which was created from wooden models, has also not shown to influence outcomes if you use that particular approach in practice. Cyriax's capsular pattern has also not been consistent in the literature, and infield classifications are also inconsistent. We know the disc does not displace in a predictable pattern with selected motions, so the early McKenzie theorists have been shown to be incorrect. We know that we can't feel very minor finite motions, such as the sacroiliac joint, are really minor movements in the spine. We don't have the ability to actually feel that. We also know that certain postures don't necessarily predict impairments, and that maybe postural problems aren't as bad as what we considered in the past. And even a more modern approach to treatment using clinical prediction rules has not held up under scientific scrutiny. So all of these theories, which I had to memorize, and maybe you did too, have not really stood up under scientific rigor. But there are three things that have stood up, and there are three ways that manual therapy mechanisms tend to influence humans. It influences humans psychologically, biomechanically, and neurophysiologically. And I'm going to talk about all three of those ways separately. Let's start with psychological mechanisms. We know that manual therapy influences the way a person thinks, and it has a very strong placebo effect. We know that if you provide manual therapy versus nothing, that typically individuals will report that they were better with manual therapy than receiving no treatment at all. That's a true placebo effect, because placebo is where the brain believes something is more beneficial than what it actually is. A nocebo effect is where someone is afraid of manual therapy, or they actually think they'll get worse if they receive manual therapy. And you may have experienced this with some of your patients who really don't want it, and if you try to give it to them, it may actually make them worse. One of the most powerful psychological mechanisms is the understanding of expectation. And this is when the patient receives something that they think is actually going to be beneficial. I'm going to talk about these separately. We know the placebo effect is influenced by a number of things, such as expectations, what they've learned, contextual cues, how they're motivated, what they've been conditioned to think, verbal cues, and emotion. All of these elements come together and can actually cause symptom relief in patients. In fact, almost every intervention that we use has some component of placebo, so that the patient thinks that they're likely to get better. The most powerful placebo that a patient can receive is surgery. And you may be familiar with the several studies that have used a sham surgery versus a real surgery and have shown that the outcomes are very similar. Any instance where there's a great deal of ceremony or preparation involved for that patient, you will see a higher level of placebo. We typically see this in surgery. You'll see this in dry needling, in injections. All of these things can cause a placebo effect. A manual therapy approach has a great deal of ceremony too, which can cause placebo. There have been hundreds of studies on placebo, and we know that you can influence the way a person experiences the treatment and thus alters their symptoms just by changing the provider. In this particular study, they had a machine provide medicine, and in the comparative group, they had an individual in a white coat that looked like a physician providing the medicine. And they found that when the physician provided the medicine, the patients reported less pain, even though the doses were exactly the same. We see this all over the place, where you change the way the care is provided and you see a stronger placebo effect. The placebo effect is so powerful that even when patients know they are receiving a placebo, they still have a placebo effect. This is why, in many cases, physicians will continue to refer patients to us because they know the patient will likely report that they're better if they receive any care than no care at all. Patient expectations are what a patient expects to receive and what they expect to happen once they receive that care. And there have been almost 10 studies that have looked at the power of patient expectations. And manual therapy is one of those interventions that is heavily influenced by patient expectations. If your patient expects to receive manual therapy, then it would be beneficial for you to provide manual therapy to your patient because it will have a very strong placebo approach. It will have a very strong positive psychological outcome. I want to, and I know some people are probably listening and they have been taught to think that the placebo approach is a bad thing. And when used incorrectly, placebo is not a good thing. But a placebo can be beneficial if we enhance the outcome for the patient, if we do things to make the patient feel that they're getting really special care, then there will be a placebo approach with this. And it's important to recognize that it's not just the psychological approach. There are physiological responses associated with the placebo approach. In other words, you will see the development and dispersal of endogenous opioids, or our own opioid system, throughout the body because of the placebo effect. You will see changes in the pituitary gland, in the respiratory centers, a reduction of cortisol, which is a stress-causing hormone, and you'll see a sympathetic nervous system response with this as well. So placebo, even though we think this is a psychological response, also has a physiological response. And in many cases, that physiological response is quite similar to many of the other interventions that we use that don't have a psychological approach. So what I tell people is, don't be afraid of placebo, embrace it. Use any of the techniques that you can that really enhance placebo, especially any of the manual therapy techniques when a person expects to receive it. Another mechanism in which manual therapy works is called a biomechanical mechanism. And this is the assumption that manual therapy changes the plasticity of tissue, it improves the range of motion, it alters the structural position, and it changes the tissue integrity around the area that you treat. The original philosophies of manual therapy were all based on biomechanical mechanisms. All the theories on why manual therapy worked were built around biomechanics, with the assumption that we structurally changed the patient, consequently, they've gotten better. The challenge to this is most of the studies show that there are only short-term or none biomechanical effects. And the few studies that actually support it are very small studies that are poorly designed and are likely biased. So out of the three, psychological, biomechanical, and neurophysiological, the weakest evidence supports biomechanical. But let's talk about what we do know that happens biomechanically with a manual therapy approach. We do know that you will see a temporary improvement in hypomobile segments. So you do see a slight increase in tissue elasticity and an increase in range of motion. We often see increased viscosity of synovial fluid with a manual therapy approach. And we sometimes see with aggressive manual therapy a change in the cross-linkage of the collagen fibers whenever a person receives a very vigorous approach. There is less evidence to support things such as intra-articular meniscoid entrapments, changes in the position of posterior annular material of the disc, but you will see some temporary change in the hypertonicity of deep extrinsic musculature. In other words, an area that's injured, the muscles will spasm around that area, and manual therapy will often cause that to temporarily relax. An emerging area that we're seeing within the literature is that there are changes in peripheral inflammatory mediators. In other words, we will see a temporary change in some of the inflammatory responses that occur around the region that receives manual therapy. There are some human studies that have looked at this, but the majority of studies have been in animals, specifically dogs, in which the injured area of the dog was treated by manual therapy, and they were able to change the inflammatory mediators temporarily. So the least amount of literature is on biomechanical, and then the next most amount is on psychological, but by far the majority of the literature supports the use of a neurophysiological approach. In other words, the main reason why manual therapy works is neurophysiologically. And neurophysiologically just means your technique is affecting the peripheral and central nervous system, causing pain modulatory approaches. This is how manual therapy primarily works. This is a really nice paper that describes the mechanisms associated with manual therapy and the primary reason you see changes in patients with a neurophysiological approach. It was published by Bialowski et al. In the Journal of Orthopedics and Sports Physical Therapy in 2018. And Bialowski and colleagues truly support that the primary reason you see any pain inhibition or pain modulation is because of neurophysiological responses. Indeed, it is a fact that manual therapy is a pain modulator. In fact, if you read on a social media website, or if someone is telling you that manual therapy doesn't do anything, then that person does not know the literature. The literature or publications on manual therapy is quite clear that it causes a pain modulatory approach. Pain modulation occurs when the body alters a pain signal as it's transmitted along a pain pathway. For example, if I had a significant amount of knee osteoarthritis, my perception of the pain associated with OA would be in my brain, but the pathway would run from the knee to the brain. And all a pain modulatory technique does is it alters that pathway. It either blocks it, which is what drugs do, or it modulates it, often decreasing it or increasing it in some cases but manual therapy typically decreases it. Now, this is important because the body modulates pain in 6 different ways. And manual therapy has been studied on the majority of these 6 ways. And I'd like to talk about that for just a second. We know the body modulates pain through the gate control theory. And this is the idea that you can gate pain as it goes from one region to the brain by shutting down particular gates, either through medication or through external application. For example, electrical stimulation functions for the gate control theory. There's also endogenous opioid modulation of pain. And this is where the body produces its own endogenous or within the body opioids to block pain that is being transmitted to the brain. This is exceptionally powerful and beneficial because endogenous opioids are much stronger than the opioids we take as medicine. And they're site-specific. So that if I had a knee problem, I know that the endogenous opioids, my own creations, would go to my knee, not throughout the whole body. Opioids that you take in a pill go throughout the whole body. And that's why we see side effects. We know there is also autonomic modulation of pain, and it has 3 different levels: dopaminergic, noradrenergic, and serotonergic. And each of these are different neurotransmitters that function to up or down regulate pain. GABA receptors are the primary transports that allow the pain to be modulated up and down the body. And the GABA receptors are amino acids. So you can also alter amino acid levels in the body. You can influence GABA receptors, and that can modulate pain as well. I already talked about placebo. Placebo is a form of pain modulation, and we use placebo all the time to create a physiological response in our body, which influences our pain. And we also have cannabinoids in our body, and these receptors are similar to if someone would smoke marijuana, that it has a similar pain relieving effect. And these 2 are ways that the pain is modulated within the body. What's important to know is that through animal and human-based studies, they have actually looked at whether or not manual therapy influences pain modulation by looking at the 6 different ways pain is modulated in the body. Manual therapy works through the gate control theory. It does have endogenous opioid modulation. It does influence autonomic modulation of pain. And even though it's unknown whether mobilization or manipulation influences dopaminergic modulation of pain, we do know that massage releases dopamine and is an effective tool for dopaminergic modulation of pain. The only one that really has not been studied is how manual therapy influences GABA and amino acids within the body. That is currently unknown. But through tens to 100 studies have all shown that manual therapy does function as a pain modulator. In other words, the mechanisms affiliated with manual therapy do influence the pain modulatory mechanisms within the body, and there is evidence to support this. One particularly good paper that I would recommend if you have the opportunity is from Vygotsky and Bruns. And what they did is a systematic review of all of the descending pain modulation studies involving manual therapy. And they did find that manual therapy influenced a number of neurotransmitters, endogenous pain modulatory elements, and it did so in multiple different ways. In fact, the evidence is so strong to support that there is a mechanism associated with manual therapy that it often makes me very angry when I hear someone say, well, manual therapy doesn't do anything. That's just simply untrue. That is someone who is ignorant, who doesn't know the literature, and maybe doesn't like manual therapy, and they're just trying to get likes on social media. But in reality, in the science behind this, it's actually pretty strong. Manual therapy has a pain modulatory approach. In fact, if I had to summarize what manual therapy did with respect to neurophysiological approach, we know it has a rapid analgesic onset. Often, patients will report a reduction of pain in a matter of seconds with manual therapy procedures. We also know that it has an immune system response. Now, it's a short-term immune system response, but it does have an effect. We know it can relax visceral mechanisms as well. And I'm not talking about visceral manipulation or some of these wacky things that you see. I'm talking about spinal manipulation or mobilization. It tends to have a calming effect on the viscera, a relaxation. It causes a central mediating effect. In other words, if a person has central sensitization or central nervous system hypersensitivity, we know that there's a temporary mediating effect associated with manual therapy. It can also have an influence on pain sensitivity. Now, I know there are many students in the audience, and it's important to recognize that your patients will perceive pain very differently across the spectrum of patients that you see. And your patients may have very high levels of pain sensitivity, meaning that very little things will trigger their pain, versus other individuals that really require a lot of stimulus to reproduce their symptoms. Patients have different pain phenotypes, and the way that they respond to injury is going to be markedly different. Your diagnoses that you see will have many different examples within those diagnoses, and patients will report pain very, very differently. And pain sensitivity can change over time. We know that if an individual has long-term pain, then there's an increased likelihood that their pain sensitivity will continue to drop over time. We know that if individuals have pain in all the different regions of their body, in other words, widespread pain, that we also know that that leads to a change in pain sensitivity. So this isn't something that is linear. It's something that takes many different paths. Pain is quite complicated. But the nice thing about it is that manual therapy influences these factors. Manual therapy has an effect. Now, in most cases, manual therapy has a short-term effect. But there are some studies that have suggested longer-term changes when manual therapy is applied. That is not the majority of studies, but there is evidence to support this, which is probably why you see manual therapy recommended in most of the clinical practice guidelines. I will provide a PDF of this slide to Gustavo if you all would like this, but if you're looking to fact check me, or if you're just interested in this particular area and you'd like to read more papers, these are all URL links to other studies that have looked at neurophysiological mechanisms of manual therapy. When I say there is a lot of research on this, I truly mean it. There is a lot of research on manual therapy. It is complicated. It is difficult to read. Some of it you may read and not understand because it really drills down to the cellular level in many cases. But there is evidence that manual therapy influences the pain modulatory elements of a person. So if you like manual therapy, you're probably jumping for joy. You're probably very happy to hear this. You may have been conflicted on what you've been told. Maybe your instructors, some support it, some don't. Maybe in the clinic you see it work or not work, and maybe you just don't know. But what's important to recognize is that manual therapy has an effect. It's a pain modulatory effect. It tends to be neurophysiological. It has a pretty strong placebo and expectation element to it, and a very small biomechanical effect to it. So yeah, it's good to know that this information is good, that there's value. But wait, what's interesting is this. Manual therapy is not exclusive in its pain modulatory approach. In fact, we know that a lot of different interventions have a similar short-term neurophysiological approach. In fact, if you look at the literature, we know that massage, kinesiotaping, acupressure, compression, ultrasound, ice massage, strain counterstrain, and other dubious activities such as moving the jaw repetitively can lead to a short-term pain modulatory approach. The challenge is taking that information, those mechanical effects, those modulatory effects, and transferring those to the clinic so that one can actually see a change. In fact, we know this. Our question is this, excuse me. Here is our question. Does a neurophysiological input or change relate to a change in clinical practice outcomes? If we perform manual therapy on someone and you see pain reduction with that particular technique, does that automatically mean that they're going to have a better clinical outcome? The challenge is this: these are not the same thing. Mechanical effects, neurophysiological, placebo, biomechanical, mechanical effects or mechanisms are not the same thing as clinical effects. Clinical effects are much more complicated. To get clinical effects, you have to change the health status of your patient. If you use a tool like the oswestry or the NDI or many of the other quality of life tools that you may use in clinical practice, you know that it takes a lot more than just one intervention to change that patient's health status. So when we look at the clinical literature on manual therapy, we often don't see as strong effect in changing clinical outcomes as we might think. That even though manual therapy has mechanisms that have been reported in the literature, those mechanisms don't automatically relate to a change in clinical outcomes. And that's a really important thing to reconcile. I'll finish on this. If you really want to make a difference in a clinical outcome, then we need to address the whole patient, not just their pain. You need to address the social component, the emotional component, the cognitive component, the nociceptive and nerve-related components, and you need to improve their overall health and their belief in their overall health. the literature has showed that that's what influences clinical effects. All of those things, not just one thing. And that's one of the reasons we haven't seen really large clinical effects with manual therapy. All right, that's my mechanisms lecture. What I'm going to do is stop sharing my screen, and I will open it up to questions if you have any from the audience.
Great chat, great presentation, thank you very much. Ahora, chat, te haré las preguntas, ¿te parece? ¿Me escuchas bien?
Absolutely. Yep.
Primera pregunta, chat. ¿Por qué crees que tenemos tantas ideas negativas con respecto al placebo? ¿Por qué crees que las ideas negativas se mantienen en el tiempo, en nuestra cabeza como kinesiólogos, en nuestra cabeza como profesionales de la salud? Si ya hay evidencia que muestra que tenemos que tener esto en mente, que tenemos que tener esto como algo que no es negativo, que no es algo que tengamos que tener ideas negativas con respecto a eso.
So I think there are two reasons why. The first reason is most of the placebo research was performed in pharmaceutical studies, where they're actually testing whether or not there's an effect of a pill versus an inert or a sugar pill. And in that particular instance, it is imperative that we tease out whether or not there is value to that particular medicine. So placebo got a very negative image because it was an assumption of no value, a sugar pill. It was only later when we started to recognize that clinically you saw a lot of placebo associated with surgery, injection therapy, dry needling, exercise, and manual therapy, that people started to embrace the placebo and say, there's value in this because it has a psychological and a physiological benefit. We will still try to identify those techniques that have a specific mechanism that is beneficial for that patient. If someone is weak, I would want to do strength. If someone is in pain, I would want to do something that's pain modulatory. We'll still try to match the treatments, but we can develop the ceremony to that in order to improve that person's overall condition. The second reason is that for a long time, we thought our interventions provided effects that were very different than one another. We thought manual therapy did something extremely different than exercise, and that ultrasound did something extremely different than electrical stimulation. And we taught it that way. If you want to do this, you need to do this one. If you want to do this one. We now recognize that there's something called shared mechanisms, and that most of our interventions, regardless of what they are, end up providing very similar outcomes and similar effects. So recognizing that, we no longer are that concerned about the placebo, because the placebo is one of those interventions that has a shared mechanism.
Perfecto, perfecto. Aquí hay una pregunta desde Brasil. Con respecto a la manipulación miofacial, ¿qué piensas sobre esos mecanismos? ¿Piensas que son similares?
That is a great question. And it is my belief that a lot of the myofascial techniques have a very similar pain modulatory mechanism that mobilization or manipulation or massage has. The problem is it has not been studied as deeply with respect to pain mechanisms. That doesn't mean that I don't think it's valuable. It just means it hasn't been studied. Your question is, do I think it has similar mechanisms? Yes, I do. In fact, I think some of the myofascial techniques have great potential for pain modulatory mechanisms and probably have good carryover to clinical outcomes as well.
Perfecto. La siguiente pregunta también es de Brasil. Te hace una pregunta. ¿Hay estudios sobre los efectos de la dosis para la terapia manual, especialmente con respecto a los grados de Maitland? Él hace como un comentario al final. A él le parece que los 2 primeros grados de Maitland son poco relevantes frente a otros tipos de terapia.
Yes, there is. I know of 2 studies. The most recent is by Suzanne Snodgrass. And she looked at the pain relieving approach associated short-term with a higher grade versus a lower grade. And she looked at this over time as well. And the higher grades were more effective than the lower grades. So your hypothesis is correct. In fact, if you really look at the philosophy of Jeffrey Maitland's grade 1 and 2, it's unlikely that we can even do a grade 1 and 2 because the assumption is that you're supposed to perform a mobilization before R1. And studies have shown that R1 occurs as soon as you place your hands on the body. So in reality, the only grades that truly exist are grade 3s and 4s, and they're differentiated by oscillation speed, and that's it. So, and by the way, Brazil is in the house. That's 2 questions from Brazil.
Ahora una chilena, ahora una de Chile, del país que queremos. Te mandan saludos desde Bolivia también, en el chat.
Yeah.
Excelente que tengamos también personas de Bolivia. Estoy agradecido de toda la gente que está acá y todos de diferentes países. Así que muchas gracias a todos por la audiencia que tenemos. Estamos muy contentos de poder contar con la presencia de chat y con la presencia de todos ustedes hoy día. Va la pregunta de Chile. Él te quiere preguntar tu opinión con respecto a placebo y la telerehabilitación. Como es sabido por los estudios, dice él, el hecho de estar con el profesional es muy importante para el paciente. ¿Qué piensas sobre eso?
So that is a very timely question because many of us have been pushed to doing rehab through telemedicine, including me. I do telerehab. I do cognitive behavioral therapy over the phone. So we know that there are many positives about telerehabilitation. One is that you tend to build a better relationship with your patient because you're forced to communicate with them more and you're forced to use your words and your allegiance to that patient in a way to make that patient better. When we're with a patient, we sometimes use our hands, heat, electrical stimulation, and other substitutes that sometimes get in the way to that relationship building. Therapeutic alliance is higher in telerehab studies than it is in traditional studies. And I would recommend that you read the work from Kim Bonnell, who is actually out of Australia, who has studied this. So with therapeutic alliance being higher in telerehab, it tells us that it's very important to build that relationship with your patient. I tell my students that the biggest difference between telerehabilitation and on-site PT is just the platform. You still want to engage the patient, you still want to educate them appropriately, and find things that are meaningful for that individual to help them help themselves. And if you can do that, if you can do that live, you can do it in telehealth. I would not be concerned about that.
That's great. Chad, una pregunta que tiene que ver con lo que estabas comentando, con lo que estabas hablando. Ya dijiste que la comunicación es muy importante. ¿Cómo crees que debemos comunicarle a los pacientes los efectos de la terapia manual? Porque hay mucha gente que se va por la comunicación con respecto a los efectos biomecánicos, ¿cierto? Quizás deberíamos mostrarle a los pacientes o comunicarlos con los pacientes de forma diferente. ¿Qué piensas sobre eso?
So that's a very layered question, because there are so many things I want to say, but I'm going to keep this brief and do my best. I just wrote a paper for a German journal describing exactly how I approach this. The first thing I do with the patient is that I tell them that if they get pain relief immediately from this particular approach, and that pain relief lasts, then they typically have a very good outcome, that their prognosis is generally very good. And that is called a pain adaptive response. The pain studies have shown that those individuals who have a quick increase and then decrease of pain with repetitive movements or any provocation, exercise, anything, that those individuals tend to have very good prognoses if they have musculoskeletal problems. So when I communicate with my patient, I will tell them, we're going to use manual therapy. We're going to look for what your response is. If your response is good, that's a very, very good sign. We're only going to use manual therapy a few visits, maybe 2, maybe 3, but our goal is going to teach you how to manage yourself. Manual therapy is just going to get us there, and then you're able to manage through exercise and through self-mobilization activities, self-stretches, other proxy treatments. So that's essentially how I communicate manual therapy with patients that I see. I do not say it's magical. I do not say it's going to realign an altered position. I never tell somebody that their pelvis is out of line. I don't do that. I tell them that it's a pain modulatory approach, and that is it.
Perfecto, Chad. Una pregunta de un profesor que yo tuve en la universidad hace ya bastante tiempo. Dice, entendiendo que la misma evidencia tampoco es una religión, ya que varía en el tiempo, es dinámica y cambia según los propios avances. ¿Qué valor le asignas, Chad, a la evidencia plus? La evidencia plus como término que resume, la experiencia clínica cuando hay técnicas que éticamente no pueden estudiarse in vivo en humanos.
So, first of all, I love what you said first, in that evidence changes over time, because it does. And what we know now is going to be dramatically different than what we know in the future. And what we need to recognize too is that we will never know everything, that there's always going to be a gap in what we learn. I'm not 100% sure I understand what you mean by plus evidence. Do you mean plus one journal, or I'm not familiar with that terminology.
Dice como término que resume la experiencia clínica cuando hay técnicas que éticamente no pueden estudiarse en vivo en humanos. Como creo que darle más importancia a la evidencia de la experiencia clínica.
Oh, okay, yeah. Yeah, I think obviously we have a hierarchy of evidence, And then in many cases, we are here, a little bit lower than where we need to be. And then, but the professor is correct. There are some things that we will never be able to study in a comparative trial. Can I give you an example? We just finished a study where we compared primary revision surgeries of the spine versus, primary surgeries of the spine versus revision surgeries of the spine. And we were looking for complications over a 2-year period of time. It was an observational trial. We could never directly compare those two interventions because a revision surgery is a second surgery on top of the primary surgery. We found no difference in complications over a 2-year period of time. And we reported that evidence to the journal and said, there's no difference. That despite what people have been saying for years, in reality, the evidence does not support that there's a difference. And that is evidence. That's not a randomized controlled trial, or it's not a direct comparison, but it's clinical evidence. And even evidence below that, something that we see, what we identify in clinical practice, if there's nothing above that that has been looked into, you have to consider that level of evidence. A Delphi study is the lowest level of evidence, but sometimes it's the only information that we have. Expert opinion. And the key is take it as high as you can go, but there are going to be some things that we cannot study ethically.
Perfecto. Se rió mi profesor de que dije que fue hace mucho tiempo, pero ya fue hace harto tiempo que salí de la universidad, hace ya más de 15 años, 13 años, así que es harto tiempo igual. Otra pregunta, chat. ¿Cuál es tu visión o enfoque sobre el tratamiento en casos de sensibilización central con terapia manual?
Yeah. So that's a really good question too. And just for everybody to know, central sensitization is a hyperalgesia. It's a hyper response. It's an amplified response to pain that is centrally mediated. And it's very challenging to treat. There are many central sensitization syndromes, and one is fibromyalgia, which I saw was #1 on your word cloud. Yeah, so fibromyalgia is a central sensitization syndrome. So does something like manual therapy work on central sensitization syndromes? Not by itself. It is only going to have a short-term effect at most. And what you'll probably do is waste your time and the time of your patient if you're mainly using manual therapy as an intervention. We know that central sensitization disorders tend to do better through either cardiopulmonary exercise, long-term, or resistance exercise, long-term. They also respond better to medication. So if I was talking to someone who had central sensitization, I would try to convince them that here are your better options. They are more difficult to do, but they're going to lead to better outcomes. And manual therapy may be like ice cream. It'll taste good when you eat it, but you'll regret it later on because it's not going to do any long-term benefit for their condition.
Perfecto, perfecto. Hay otra pregunta también de lo mismo, con respecto al qué valor le entregas a la terapia manual en dolor persistente. Parecido, pero creo que contestaste perfecto. Vamos por otra pregunta, y creo que es la última.
Can I add
¿Te parece?
something to that?
Yes,
Okay.
por favor.
So persistent pain isn't always central sensitization.
Yes.
So I think it's incumbent upon us to really tease out what the primary problem of that patient is and why they continue to have persistent pain. And central sensitization, I think, is very telling. The patient will have they'll be hyper responsive to smells, to cologne, to clothing textures, to lights, to a number of things. And persistent pain may be because they continue to have a peripheral trigger that continues to aggravate them. So I do spend some time to actually look for that.
Entendido. Se entendió perfecto.
Yep.
El dolor persistente es algo más,
Yep.
más global y la sensibilización central es algo bien específico que te preguntaron, pero diste una respuesta. Me da la impresión de que la pregunta iba hacia allá, hacia los pacientes que presentan dolor persistente con sensibilización central. ¿Sí?
Okay.
Ok, voy a la última pregunta. ¿Te parece, Chad?
Yep.
Esta pregunta es más de la parte más bien de investigación. Realmente te preguntan si podemos realizar una intervención simulada en un estudio randomizado controlado con placebo. Se refiere a que una intervención simulada no producirá el mismo estímulo que la intervención real, por ejemplo, en la manipulación. No sé qué opinas sobre eso.
Yeah, so that has actually been studied, and there's even a systematic review that has evaluated the effectiveness of a placebo manual therapy approach. And it's very controversial. A majority of individuals will say that they do not think that you can do a manual therapy placebo, that patients will recognize that they're not getting a manual therapy approach, and that will influence them psychologically. Others have used a placebo manual therapy by a very non-specific, just global force that they impart on that person. We did a study in 2016 in which we did a very specific manual therapy approach to the affected area of the patient. And the placebo group received just hitting the patient in the low back at L4 and L5. And we followed those individuals out for 6 months, and there was no difference between the two groups in pain and disability. But there was a difference in the patients who received the specific manual therapy on what they felt, how much they felt they improved. They scored 2 points out of 7 higher than the placebo group and how they thought they improved. So the specificity of the manual therapy may have a pretty good placebo approach, but it did not change the health outcomes of the patient.
Perfecto, Chad. Apareció una nueva. ¿Te la puedo hacer o estás con poco tiempo? ¿Puedo hacerte la última?
No problem.
¿Cuál es tu opinión sobre el uso de educación en dolor en sensibilización central combinado con terapia manual?
So if you look at pain education by itself, it has no effect. It doesn't seem to help at all. If you combine it with exercise, with self-management, or with manual therapy, you're likely to have a stronger effect. I think what we have learned over the last 5 years is there is no silver bullet. There's no perfect management approach. And all the approaches have a small effect. And neuroscience education has a really small effect. Cognitive behavioral has a very small effect. Manual therapy has a small effect. Exercise has a small effect. Everything has a small effect. And pain neuroscience by itself, without any other intervention, has no effect. So if you're going to use it, combine it with some of these other interventions to enhance its value.
Gracias, Chad, por las respuestas, muy buenas todas. Te agradecen aquí en el chat por millones. Muchas gracias, felicitaciones por la presentación. Desde México, desde el sur de Chile, desde el norte de Chile, desde Bolivia, como te dije, desde Argentina. Hay mucha gente que te está agradeciendo por tu charla y por tu presentación y están todos muy agradecidos de que estés hoy día con nosotros. Incluso te agradecen, hay una persona que te está agradeciendo por un paper de discapacidad y dolor que le encantó, dice Sebastián Ortiz, que es chileno también. Así que muchas gracias por estar hoy día con nosotros, Chad, y voy a darle la despedida a todos. ¿Te parece?
Thank you, Gustavo. Thank you, Natalia. I love South America and Mexico. So thanks again for inviting me.
Quédate unos minutos porque nos despedimos cuando terminemos el streaming. Ahora voy a dar por terminado el streaming y unos minutos para despedirnos. ¿Te parece?
Okay.
Quédate unos segundos. Bueno, muchas gracias a todos. Muchas gracias por dejarnos todas las preguntas acá en el chat. Creo que es una de las charlas que más se movió el chat de todas las que hemos tenido. Agradecidos a todos por estar desde prácticamente toda Latinoamérica, incluso de muchos países con nosotros. Así que les agradezco a todos y espero que verlos en las próximas charlas que vienen a continuación, que vienen muchas sorpresas. Así que gracias a todos y gracias a Chat por estar con nosotros.